So these are my disclosures. I have a few honorarium and research funding. So for the outline of today, I am going to be talking in terms from TTP, looking at in-hospital mortality and long-term outcomes of TTP, obstetric complications of congenital TTP, some data on post-hoc analysis of the HERCULES trial, which I will briefly mention, the real-world evidence of the use of eculizumab and the cost-effectiveness of it. And in terms of atypical hemolytic uremic syndrome, we'll talk about a protocol for discontinuation of eculizumab. So in physiological conditions, you have ultra-large von Willebrand factor multimers that are secreted from endothelial cells. And these ultra-large multimers are cleaved by ADAMTS13 into smaller multimers. And this is how physiologically it happens in our natural circulation. But when you have presence of autoantibodies against ADAMTS13, or if you have a congenital deficiency ADAMTS13, you have a large circulating multimers that then bind to platelets and causes microthrombi, platelet aggregation, and this results in sharing of red cells as it circulates around the body, producing schistocytes. And so this von Willebrand platelet aggregates are large enough to form microthrombi that then cause tissue ischemia, a lot of platelet consumption, which is why you get a thrombocytopenia. And of course, the schistocytes is how you determine that someone has microangiopathic hemolytic anemia. So we have been taught that TTP has a very high morbidity and mortality, and it remains one of the few blood disorders that would get a hematologist out of bed to come in to assess the patient. And this year, there were a few abstracts that look at the outcomes of TTP using national databases and registries. And so one of them is using the National Inpatient Sample. They looked at, from a cohort from 2002 to 2017, they used ICD-9 and 10 codes for thrombotic microangiopathy. There isn't an ICD-9 or 10 code for TTP alone, so you have to use thrombotic microangiopathy, which is kind of a huge catch-all phrase. But the way they tried to hone down on TTP is that they made sure there was a procedure code for therapeutic plasma exchange. And so this revealed about 6,000 patients, and they found that the overall inpatient mortality was about 9.1%. And over the years, the admission rate for TTP remained about stable between 5 to 7 per 100,000 admissions over the years. These patients all had a very high complications reported. So the most common complications, acute kidney injury, followed by acute respiratory failure, incident dialysis, and so on. The second study, in this study, they use Medicare fee-for-service and also looking at a sample of private commercial insurance from the Innovalent MOR2 registry. So this authors set out to describe immune-mediated TTP-related resource utilization, costs and complications, and more importantly, overall survival among US Medicare and non-Medicare population. So they look from 2010 to 2018, and just looking at the Medicare fee-for-service alone, there were about 1,500 patients. About 70% were treated at academic medical center, about 30% were non-academic center. The overall inpatient mortality was about 15%, and it was actually higher than non-academic center. This was why I found interesting that they were able to calculate the cost utilization, where one inpatient stay for TTP amounted to almost $200,000, but the DRG payment is only $30,000. Next, what they did was they performed a matched cohort of Medicare patients with and without TTP, about 833 patients in each cohort. And they found that the 1-year survival rate among the patients with TTP was 71.8% versus 95.6% for those without TTP. And during your 2-year survival rate, it was even lower at 66.6% versus 91.1%. This Kaplan-Meier curve here on the right for the overall survival shows that in patients with TTP, which is the blue line here, and your matched cohort of patients without TTP, which is the red line here, you can see that after the first index event, there is consistently lower overall survival in patients who had TTP and survived their first event. This higher mortality that's seen in long-term follow-up was also seen in a registry that was done combined between Johns Hopkins University and the Ohio State University. They have a registry, and they looked to evaluate the long-term mortality and causes of death in patients that survived their first TTP episode. So in their cohort, there were 213 patients that survived the first episode. And when they followed them up for over 5 years with a range from 0.7 to 11 years, 29 patients had died in that cohort. And so then they look at the mortality rate in these patients and compare them against a reference population, which they call like the general population. And they found that the median age of death among those that survived the first episode was 49 years versus 78.7 years in the general population. And then if you look at this graph below, the mortality rate in survivors was as high as 2,283 per 100,000 person years versus 1,200 in the reference population. And this higher mortality rate was seen regardless of ethnicity or sex. In their cohort of 29 patients, they found that the most common cause of death was either relapsed TTP or cardiovascular disease, and then followed by cancer and infectious disease, and the last one was unknown. So this finding that cardiovascular disease is a leading cause of death among TTP survivors is similar to the Oklahoma TTP registry cohort run by Jim George. And it reminds us that when you treat patients with TTP, you're not just pre-treating the acute event, you need to follow them up in a long-term period because there are other comorbidities that needs to be addressed. And now if we move on to congenital TTP, the authors in this study performed a systematic review using Medline and PubMed over the last 20 years. And they looked at 35 women with 61 pregnancies who had no prior diagnosis of congenital TTP and did not receive plasma prophylaxis. When they synthesized the data, they found that the median gestation weeks when they were diagnosed was 23 weeks with a range of 7 to 37 weeks, which reminds us again that TTP can occur at any trimester. They found that about 1/3 occurred at less than 20 weeks of gestation. And a reminder for some of us that preeclampsia, which is sometimes misdiagnosed or more commonly diagnosed than TTP, rarely occurs before 20 weeks gestation. And about 17% of these patients occurred in the first trimester when they developed complications of TTP. And when I show you the table here, 34 women out of the 35 had severe complications during their pregnancy. And if you look at pregnancy numbers alone, 49 out of 58 pregnancies had severe complications. So again, this confirms the alarmingly high prevalence of obstetric complications in congenital TTP and reminds us that we need to consider this diagnosis when a pregnant woman presents with microangiopathic hemolytic anemia and thrombocytopenia at any trimester of the pregnancy. So if we were to move on to eculizumab, I believe most of us are familiar with, but for those of you who are not, it is a humanized variable domain-only immunoglobulin fragment that targets the A1 domain of von Willebrand factor. So if you recall, when you don't have ADAMTS13, your von Willebrand factor that's ultra large then binds to a lot of platelets via the platelet GP1B receptor. But the presence of eculizumab binds to this receptor, and so the ultra large von Willebrand factors are not binding to platelets, and the platelets can freely circulate. So the approval of eculizumab was through the HERCULES trial, and very briefly, this was a randomized phase 3 clinical trial where patients were randomized to receive standard of care and any other immunosuppressive agents as per provider preference versus standard of care and eculizumab. And they recruited 145 patients, and all patients received a loading dose followed by 10 milligrams of sub-Q injections for 30 days. And depending on how the patient responds, you can do an extension for another 28 days for a total of 2 months. The primary outcome for this study is the time to normalization of the platelet count. And they found that in the eculizumab group, the median time to normalization of platelet count was 2.69 days, which is significantly shorter than 2.88 days in the placebo group. And if you look at the graph here, at any given time point, patients who received eculizumab were 1.55 times more likely to have normalization of platelet count compared to those on placebo. They had some other secondary outcomes which are shown here, but before I go into it, I think it's worthwhile talking about how they define this secondary outcomes. So refractory means, in this study, a lack of doubling of platelet count after 4 days of treatment and an LDH level that remained above the upper limit of the normal range. Recurrence here means a new decrease in platelet count after initial normalization. And if this occurred within the first 30 days, this is called an exacerbation. And if it occurs after 30 days, it is called a relapse. And so you can see here that patients who received eculizumab needed less days of plasma exchange, needed less days of hospitalization. There were patients who were refractory in the placebo group, but none in the eculizumab group. And there were a higher number of patients who had exacerbation compared to eculizumab. However, it's worth noting that in terms of relapse, meaning that you had a recurrence of TTP after 30 days, there was 6 in the eculizumab group and 0 in the placebo group. So this is understandable as eculizumab is not a disease-modifying treatment. So the reason I went through the HERCULES trial because it's useful to know that to understand some of the post-hoc analysis that was presented at ASH this year. This first one was looking at a subgroup of patients who did not meet the definition of refractory TTP, but had a complicated disease course despite receiving daily plasma exchange. And this definition of suboptimal response is decreasing platelet count and increasing LDH after an initial but non-sustained improvement. And what they did is they wanted to look at the outcomes of these patients with suboptimal response. They had no patients in the eculizumab group that fulfilled this criteria, this definition, but there was 8 patients in the placebo group that demonstrated a suboptimal response to plasma exchange. And if you look at this table here, this shows the baseline characteristics of the 8 patients. You can see that they all have variable baseline characteristics. Yeah, some of them had normal troponin, some had elevated troponin. Some of the platelet counts was less than 10, and there was one at 82. And again, the serum creatinine was all over the place as well. And such, no one clinical characteristic can predict if someone will have a good or suboptimal response to plasma exchange. And they found that in this suboptimal group, the median time to achieve platelet response was almost 11 days versus the original 2.88 days in the overall placebo group. Similarly, the median time to stop plasma exchange was 13.5 days versus 7 in the overall placebo group. And in these 8 patients, 5 of them had exacerbation even after they had suboptimal response. So what the authors commented, and the authors were all PIs of this HERCULES trial, they said that this highlighted the importance of the fast and sustained protective response observed with eculizumab treatment in patients with TTP. They had a second post-hoc analysis that looked at the durability of the platelet response. And what they did in this is they set out to characterize the durability of platelet count response in the HERCULES trial. And here they define the platelet count response as achieving a platelet count greater than 150, followed by cessation of plasma exchange within 5 days. And they define these patients based on fast platelet response or slow platelet response. And fast is less than 3 days, and slow is greater than 3 days. And so you can see here that, that in the placebo group, about more than, so in terms of fast response, almost 80% of patients in the eculizumab group had a fast response, where over half of those in the placebo group had a fast response. But we look at the number of patients with exacerbation, almost half the patients that had a fast response ended up having exacerbation versus only 4% in the eculizumab group. Similarly, in a slow response group, there was a higher percentage of patients who developed exacerbation at placebo compared to the eculizumab group. And so eculizumab reduced the number of exacerbations in both the fast and slow platelet count response group. As with any drug, we kind of want to look at the safety, and the safety in the HERCULES trial showed that the most common adverse events was bleeding, with 46 in the eculizumab group compared to 35 in the placebo group. And some serious adverse events of bleeding was also higher in the drug group. So eculizumab has been shown to have faster time to normalization of the platelet count. It results in lower rate of TTP recurrence during the trial than placebo. It reduces the number of exacerbations, plasma exchange, and hospital length of stay. But it's important to remember that eculizumab is not a disease-modifying treatment. it is an adjunct to current management, and its greater benefit seems to be in its early administration. And this was approved in the European Union in 2018 and approved in the US in 2019. As well as with any other new medications, as clinicians, we want to know what is the real world evidence for using this. And there have been a few countries that have reported their experiences. And so the first one is this one from Germany that was published in, I believe, Blood Advances in July. And what they did is they were looking at people who first presented for first-time presentation of TTP, and they were on plasma exchange and steroids. And if it was an exacerbation, they were given rituximab. And so they had 60 patients overall, 35 frontline and 25 exacerbation. Since the drug is new, it takes time to get the drug. And so the time to eculizumab from diagnosis was about 3 days. They had no control group, and they showed that the days to platelet normalization was 12 days. The number of plasma exchange was 9 days. The hospital stay was 18 days, and exacerbation was 2. And then the United Kingdom published their own study came out in Blood in November this year. This time, similarly, they looked at patients who presented first time with TTP, and they all received plasma exchange, steroids, and rituximab. They had 85 patients. Their time to Kapla was 2 days. And because, again, they weren't going to do a randomized control trial, so they compared with a historical cohort, and they had 39 patients. And what they found is that the day to platelet normalization was 4 days in the eculizumab group versus 6 days historically. Again, the days in plasma exchange, 7 days versus 9 historically, and all the numbers all look better in the eculizumab group. Similarly, on the same day that the United Kingdom study was published, the French also published their own study. Same treatment, they had 90 patients, but the French was able to get the drug faster. They started everyone on the day they were diagnosed. And again, their control group was plasma exchange, steroids, and rituximab. They had 180. And as you can see, shorter days in platelet normalization in the eculizumab group, shorter days with plasma exchange. And during ASH, there was 2 more abstracts that was published, both in Spain. I'm not going to list them here. And the first one was a single center study where they look at 9 patients in the eculizumab group and 9 patients in traditional group. And as you can see with the numbers, it's always shorter in the eculizumab group. So it's somewhat reassuring that the real-world evidence of the use of eculizumab mimics the clinical studies. In terms of adverse event, I summarized the adverse events seen in all these 5 different studies. And the most common side effect, I would say, is an inflammatory site reaction. There were some bleeding events in the eculizumab group, naturally, because when you have a nano antibody against von Willebrand factor, you are kind of producing a phenotype of patients with von Willebrand disease. But overall, nothing that was out of the ordinary or what we would not have expected. So the next step to look at is cost effectiveness. So eculizumab, for some of you who are unaware, is $7,000 per injection. And so currently, based on the way it's prescribed or dispensed, where you have 30 days use, it can work up to about $250,000. And so what these authors looked at was to look at the cost effectiveness of using eculizumab in addition to standard of care, based on the results of the phase 2 trial and the phase 3 HERCULES trial that led to the approval of eculizumab. They made some assumptions, and the costs here for plasma exchange ICU day were calculated by the authors when they published a prior paper. And so this is how they calculated this. And so you can see that the standard of care arm would be about $83,000, whereas if you use eculizumab, it's about $323,000. So it adds significantly to the cost. But what we want to know is what is the ICER, which is the incremental cost effectiveness. So ICER is calculated based on cost of A minus cost of B divided by benefit of A minus benefit of B. And in this case, A would be eculizumab and B would be placebo. And based on the HERCULES trial, the authors calculated that there's an improvement of quality adjusted life years of 0.26 when you add eculizumab in addition to the standard of care. To avoid potentially confounding factors that could bias their analysis against the addition of eculizumab, what the authors did is they stacked all their assumptions in favor of eculizumab. So they did not include the cause of bleeding complications, and they equated the cost of relapse to exacerbations, although we know that a TTP relapse costs more because this means the patient has to come back into hospital, have the line placed again, and being admitted again. And when they projected this assumptions over a 5-year period, the ICER for adding eculizumab is $1.5 million with a confidence interval between $1.2 to $1.7 million. And they did 10,000 Monte Carlo stimulations with sensitivity analysis and found that the standard of care is preferred all the time. And so the authors asked the question at its current US price of $7,000, is eculizumab cost effective to use at this time? And I will leave it to the viewers to decide this on their own. My last study now would be looking at atypical hemolytic uremic syndrome. As you know, the standard of care of this is using a terminal complement inhibitor, either eculizumab or its long-acting agent called ravulizumab. The issue with treating these patients is that the ideal duration of treatment is not currently established. And currently we recommend using indefinite treatment, although recent studies have suggested that patients can safely discontinue therapy. And so this is an oral abstract that came out of Johns Hopkins University where they described their physician-directed eculizumab discontinuation and monitoring protocol in a prospective cohort of 32 patients that were diagnosed with atypical aHUS. So this is their protocol. So firstly, the patient had to be in remission where there was no evidence of TMA, normal renal function or a stable at their new baseline, no active trigger, and again, this is a shared decision making with the patient. The patient has to agree to discontinue and they are willing to comply with monitoring. And if the patient's not willing to, or they don't fit any of these criteria, you continue eculizumab. But if they're willing to, then you would stop and monitor these labs, which includes CBC, reticulocyte count, creatinine, LDH, CRP, urine analysis, and protein creatinine ratio. And it gives you the frequency you would do it 2 weeks from the last dose, and then every week for 2 weeks, and then every 2 weeks for 3 weeks, for 3 times, and then every month, and then every 3 months onward. And then if from these labs, if you notice a recurrence, you restart eculizumab, or you only reconsider eculizumab during high-risk periods, for instance, if they're going for surgery, if they become pregnant, or they have any inflammatory disease. And in their 32 patients, 25 agreed to discontinue eculizumab. And of these 25, there were 5 relapses down here. And of these 5 patients who relapsed, 4 were retreated and achieved remission without decline renal function. Unfortunately, 1 patient died due to hypertensive emergency in the setting of non-adherence. And so what the authors felt is that eculizumab discontinuation with close monitoring is safe in the majority of patients, and there are low rates of TMA recurrence which can be salvaged with retreatment. So in summary, based on what we've seen at ASH this year, TTP remains a disease with high morbidity and mortality, both during the index event and in long-term follow-up, and has very high healthcare utilization costs. Similarly, there's very high prevalence of pregnancy-associated morbidity in congenital TTP. Post-hoc analysis of HERCULES study tells us that showed the importance of fast and sustained response observed with eculizumab, and the real-world evidence used in multiple countries now support the findings of the HERCULES trial. However, based on the cost in the US, current decision models calculate that the use of eculizumab in the US is not cost-effective. And finally, in the atypical aHUS realm, eculizumab can potentially be safely discontinued as long as close monitoring is available. Thank you for listening.
Wow, excellent presentation, Dr. Lim. Really good presentations in this session.